Start the session.
This conference will now be recorded.
We'll start because we're already 10 minutes, and I think people will slowly join in. Yeah. So today's topic is PEM management and complications. In saying that it is totally your theory thing. Okay, it's not much of PEM or malnutrition cases that we are seeing nowadays because of the area we are in, and the economic status is getting better day by day. So yeah, not that you won't see, but yes, probably we may not see, but yeah, this is but definitely a important theory question. So this will be more of academic interest than any practical thing. Of course, medicine is practical. It's more of academics. Okay. Yeah, protein energy malnutrition. This was the previous nomenclature. Now people are using SAM. Okay, SAM for lesser age group, severe acute malnutrition with the criteria and management of SAM. So WHO prefers using the word SAM. Okay. Yeah. Coming to the topics, because why usually management and complications, why we are doing complications now is it is the complications that we are worried about protein allergy malnutrition, and how do we manage the case is you managing the complication is in turn managing the case. Okay, so coming to the complications of PEM, which we are worried about is hypoglycemia, hypothermia, infections, like whether it is bacterial, viral, fungal, or hypokalemia, hyponatremia, dehydration, and you just remember everything comes down. Okay, sodium, potassium, glucose, temperature, and fluid, that is dehydration. Okay, and eventually can lead to heart failure. Okay. Okay, and infections, of course, because of your propensity, your immunity gets hit, and the propensity of you getting an infection is higher. Okay, these are the complications. These are the heads we are going to deal with, and this is how the management goes by. Okay, this is of theoretical importance. You write these complications, you will get you can score half of the marks of the question. Okay, this is an essay for you guys. Okay, so you can easily do half of it. Okay, now regarding the WHO of inpatient, okay, there is outpatient management and inpatient management, but now coming to the inpatient management, the general principle of routine care, how we take care of the SAM kit. SAM is severe acute malnutrition. Okay, emergency treatment of shock and severe anemia, and treatment of associated conditions and failure to respond to treatment. And yes, once you have given the treatment, when to discharge, and when do you say that the child is completely recovered. These are the heads that we are going to deal in with. Okay, coming to the general principles, I mean, how do you manage a case of severe acute malnutrition? Is most basically divided into two phases. One is stabilization phase, like you have received the child is severely malnourished, the very sight of it is not so pleasant. Okay, so you want to either the child is in distress, shock, or a circulatory shock, very dehydrated, emaciated. That is to just stabilize the acute condition, and then once the child is stabilized with the conditions, like your ICU setup, or if you want to take the child to an ICU, give fluids, give resuscitation, and then you settle the child like that. It is the stabilization phase, and then rehabilitation phase. Once the child is stabilized, now you want slowly to increase the calories, slowly to increase the proteins to the child, and that is your rehabilitation phase. Okay, remember these two things, very important. You just put it on paper, you score marks. Stabilization and then rehabilitation. Okay, this is just like your disease thing in SPM, right? The last one is rehabilitation, disaster disease rehabilitation thing. Yeah. Yeah, note that treatment procedures are similar, whatever be it marasmus and kwashiorkor. Previously there used to be the marasmus and kwashiorkor. Now mostly everything is severe acute malnutrition, that is SAM. Okay, and yeah, treatment protocol is the same, whatever. If this is all based on your adaptation, disadaptation, or the other thing. Okay, yeah, coming to the 10 steps. These 10 steps are important. Please do remember them. You by heart, make a mnemonic. I don't know how you do it, but you just do this. This is the table. If you can draw this table, this is the thing, and you will get good marks. If you draw this, you write the rubbish, nobody minds. You do this, this is it. Okay. Yeah. Hypoglycemia, because hypoglycemia is an emergency, so there is nothing like you have to wait for it. You have to do it very fast. So in the first day 1 to day 2, you have to get the sugars ready for the level. Okay. Then hypothermia, the temperature. If the child is hypothermic, it is nothing like you have to take 2 to 3 days time to ah, yeah, sorry. Yeah, hypoglycemia, hypothermia, you just do the temperature and let it come down. uh, and then you rewarm the child. Okay, that is also an immediate thing, that is to stabilize the child. And dehydration, of course, if the child is dehydrated, we are not going to wait for time. We are going to act fast, and then correct dehydration. That is also into the first 1 or 2 days. Okay, that is the main, these three: hypoglycemia, hypothermia, and dehydration, because these three can kill or severely morbid the child. Okay, so these are the top 1 2 3s. Okay. So that has to be dealt on a faster basis, or to be attended early. Okay. Then coming to your electrolytes, as we discussed, it is everything comes down: sodium, potassium, all this, all the things do come down. Okay. And then the electrolyte correction will take time. It is there in the, because if the child is severely hyponatremic or severely hypokalemic, you have to supplement from day one, from the very moment we see the child. Okay, so from stabilization it has to start, and then it can extend up to weeks till rehabilitation occurs, because by means of resomol or something, you have to replenish the required sodium and potassium day by in on day-to-day basis. So it will take weeks. Electrolytes takes weeks. Okay, you just remember week has two e's, and electrolytes has e, starts with e. I don't know how you remember, but you do this. Okay. Yeah. Then infection, all the antibiotics we do, because immunity is less, or immunity got hit, so we have to do antibiotics. So obviously for infections, your antibiotic course usually lasts for a week. So till day 7 you have to do it, the infection part. Okay, by day 7 you have to make sure that the infection has been controlled. Okay. And then coming to micronutrients, obviously everybody should agree with this, right? Micronutrients, you have to give it for months together, not just weeks. You have to give for months together. But there is a catch in this: iron you should not give in the first, in during the stabilization phase, because it hinders the absorption. It causes gastritis, it causes vomiting, it can cause uh, mal acceptance of the diet. So don't do iron in the early stage. We'll do iron in the rehabilitation stage. Okay. But the rest of the micronutrients, your zinc, your selenium, your magnesium, your manganese, all the things, you do it from the day one. Okay, till weeks to months you can give it so long. Okay. And cautious feeding, yeah, obviously cautious feeding, the first few days you have to start it fast, because you can't keep on doing IV fluids for the child, or you can supplement it from external source. So obviously we may have to give it for from the start. The two, by a week's time, we have to see through that, yes, the child is taken by him or herself, and the child is doing well with the feeding thing. Okay. And then catch up growth, as the name suggests, it is the catch up growth that has to be dealt with rehabilitation. No, there is nothing of catch up growth or the weight gain that we are going to see in the first acute phase or stabilization phase of first 1 week. Okay. And then sensory stimulation, you have to encourage the child into, because of this dehydration, electrolyte abnormalities, hypoglycemias, and the child is malnourished, emaciated. The child will be in a lot of lassitude and easy fatigability. You need to essentially need to stimulate the child to get interaction with the mother or the family or the peers. Okay, that will take some time. That is for weeks to months. Okay, then preparation for follow-up also is a plan for rehabilitation. Yes, these 10 points, okay, remember, even the examiner is going to see this. Did you do your 10 points or not? You make a mnemonic or do whatever, just but make sure that you write these 10 things, and if preferentially these table, it is just line diagram, it doesn't take much time for your exam to, it hardly takes 20 seconds. Okay, so this is the most important, this is the thing. So we took some time to deal with this. Okay, just remember, there is a stabilization phase, there is a rehabilitation phase, and the first three things which can kill the child or which can severely injure the child are kept here, and in 1 or 2 days they have to be addressed, that is dehydration, hypothermia and hypoglycemia. The rest can take time. Okay, just remember this. Yeah, why it's not changing. Yeah. Okay, coming to the step one, your hypoglycemia. We will do these 10 steps. Okay, that is the management, that is the complications. Okay, yeah, first step, you do hypoglycemia. How do you do is, if your blood sugars are less than 54 or 3 millimoles per liter, or if the child is dull, sick, and if the parameters are coming low, like your mid-arm circumference is less than 11.5, your pedal edema is present, and less than 2 standard deviation weight, then we have to and lassitude child, fatigue child, you should imagine, if the blood sugars are not, if the value is not there, you should think that the child is hypoglycemic. And even a conscious child who is able to take, well, you give 10% glucose orally or ng tube. Okay, ng tube is because to uh, prevent any aspiration in a otherwise drowsy, lethargic child. Okay, and if the child is unconscious, completely knocked out, and lethargic or convulsing child, because convulsion can be because of hypoglycemia, convulsions can be because of electrolyte imbalance, convulsions can be because of the infections that the child has got it from because of the poor immunity. Okay, then we do IV glucose, 5 ml per kg, followed by, if the child is stabilized, then you do this 50 ml of 10% glucose or sucrose through NG tube. Okay, start 2 hours early, feeds day and night. This is important. This may seem usual, but night, because it is nothing like the child has to, like most of us, the child, we can't let the child to sleep at 10 o'clock and get up at 6 o'clock and then again feed the child. We can keep the child starved at 8 to 10 hours. Okay, you have to feed the child at night also. So that is the point. That's the catch in this. Okay. Coming to the hypothermia, that is your hypoglycemia. You give glucose. That is basically okay. The next thing is hypothermia. If the number numericals, keep an eye on the numericals. If the axillary temperature is 35 degrees centigrade less than, or rectal 35.5 degrees centigrade or 95.9 Fahrenheit. Okay, rewarm the child. You cover the child with cloth or warm blanket. Keep it under a. Nowadays we are not seeing this incandescent bulbs, the 100-watt bulbs. They were used previously to produce heat to the room. Okay, they are not so much energy efficient. So now everybody shifted to LEDs. So nowadays, which is very hard to see the bulbs, 100-watt bulbs. Okay, we used to keep in, when we did, we used to keep those 100-watt bulbs and keep the room warm. Okay, yeah, or you can do KMCs, that's kangaroo mother care, bear skin to skin contact. Okay, and then comes the dehydration. These three are important. Hypoglycemia, I'm repeating again and again so that you remember this: dehydration, hypoglycemia, hypothermia. Okay, all these three important. Okay, dehydration, yeah, difficult to estimate dehydration, usually clinical signs alone, because the child will give emaciated, thick, folded skin. The pictures are not there actually, otherwise I would have shown. Okay, yeah, assume all children with water diarrhea will have dehydration. Just think that the child is dehydrated. Do not use IV route for dehydration except in case of shock. This is because the fluid may be normal, but the extravascular water content may be low. So there is no point in giving it more intravascularly. If you are giving more intravascularly, we are going to dilute the electrolytes more, and we are going to dilute the water content more. So the heart gets more load, and already the heart is compromised because of poor circulation, and if you are giving IV route, there's every chance that the heart can fail. Okay, so don't be very eager to put a line and throw fluid into the vein. Just make sure that you do it orally, mostly if the child is accepting. Okay, only if the child is in shock, if the cold peripheries are there, if the child is altered sensorium, if the blood gases are very bad, then obviously we have to resuscitate on the basis of shock management. Okay, that we'll be dealing subsequently. Okay, this is just like the preliminary management. Okay, the general principles. Yeah, continue feeding if the child is conscious and taking feeds. Okay, even the child is dehydrated. Now, how do you assess the child of dehydration and severe malnutrition? Because severe malnutrition and dehydration all will be the same mode. Okay, mental state both will be irritable, mouth and tongue and tears. If they are dry, we can think that it is dehydration. If the mouth and tongue and tears are present and the child is dull, drowsy, then maybe it is because of severe acute malnutrition. Okay, and skin turgor can be present in both. Okay, even in dehydration and also in SAM. Okay, and edema and hypovolemia can coexist with both dehydration and this thing. Okay, so how do we diagnose this? History, always history. Like our case presentation goes by, you just see the history. If there is history of diarrhea, vomiting, and poor feeding and child neglect, whatever be it, if there is such history, then you should think that dehydration is also there. Okay, increased thirst, the child eagerly takes water or something liquidy. So that is another sign that the child is having dehydration. And sunken eyes, obviously, if you look at, then comes the examination. Sunken eyes, prolonged capillary refill time, and weak pulses and decreased urinary flow, and all these things will give a clue that the child is going into dehydration. And difficulty using clinical signs alone, it is always better to use some dehydration. Okay, and as again I'm insisting, don't put IV line, don't be very eager to put IV line and throw fluids into the vein just because the child has come to your clinic. Just if the child is taking orally, oral route is the best because it passes through the intestines, it passes through the kidneys well, and if the volume is more, only then it will go into the kidneys. If you are directly putting fluid into the vessels, the heart takes the load very fast, and it gets easily failed faster. Okay, so this is something called what to give is your rehydration solution for malnutrition, that is resomol, the acronym. Rehydration solution for malnutrition, how does it differ from WHO? Is it gets less solute load. Okay, and it is kind of more glucose. Okay, because the child is hypoglycemic, so there is more glucose, 125 against 75 for normal ORS, but the electrolytes are being tailored so that they're well suited for this thing, because electrolyte management should take weeks. You can't directly push in all the electrolytes into because just because electrolytes are low, we can't push it acutely. There is a time, slowly we have to replenish. Okay, so sodium has been decreased and glucose has been increased. Just remember this. Yeah, potassium also gets increased. Remember 75, 45, 20, 40, 75, 125. Okay. Yeah, which should be used. Low osmolarity ORS with potassium supplementation is the best actually. Yeah, that is what Resmol does, right? Resmol has 40. Okay, Resmol, which is not available. So there is IAP endorsed low molecularity WHO ORS type is present, that we can make it with the normal ORS that is available, with the mixing of with 2 liters of water and with other mineral components. Okay, yeah, and then comes your electrolyte imbalances. That is the fourth one. As we discussed, electrolyte has E, so it takes weeks. Okay, plasma sodium may be low So body sodium is usually high because sodium supplementation may increase mortality. So you don't be eager in putting the electrolytes. That is the reason why we decrease sodium in case of resomol, because the body has sodium, but it is not in the vascular compartment. It has moved into the cells because body wants to make the tissues less dehydrated. Once the sodium is there, there will be water, and all the tissues and the cells are well hydrated. Even the intravascular compartment is compromised. Okay, so don't try to put more electrolytes into the circulation. And potassium, magnesium are being hit. Actually, they will be deficient and need supplementation. May take at least 2 weeks to correct. Okay, even electrolytes you are not going to do it very fast. Potassium and magnesium, yes, they can be deficient. So that is why your resomol contains 40 potassium against 20 of normal ORS. Okay, if edema if present is partially due to these imbalances, and do not treat edema with diuretics. Once you do diuretics, your free water will be lost, and again it will become high concentration in intravascular volume. So you are going to mess up with the intravascularity. So don't do diuretics in case of PM edema. Okay, that is because of hypoproteinemia and these subtle electrolyte imbalances. Okay, that is the management of electrolytes. Don't do more sodium. Do potassium and magnesium, and don't do diuretics to decrease the fluid. Okay, and yeah, prevention of infection. Yes, they are already malnourished. They are recepting ducts for infection. Every here and there, virus, bacteria, and fungus, they'll be catching up, and they'll happily growing it. Okay, yeah, broad spectrum antibiotics, because we don't know what the kid is catching. Okay, so you do broad spectrum antibiotic, gram positive, gram negative, everything. Okay, hypoglycemia, hypothermia usually coexist with infection. Hence, if there is present, we should think that the infection is also present, and you can do. See, in medical literature nowadays, everybody is like, don't do antibiotics here, don't do antibiotics there. You can wait and all stuff. But this is one condition where you do antibiotics freely. You just assume and you can start antibiotics. Okay, PEM management, the SAM management. Okay, yeah, no complications. You can do cotramoxazole. Child is absolutely normal. You do cotramoxazole. Very sick child, you do penicillin with gentamicin. That is ampicillin with gentamicin. This is a very broad spectrum. It will cover both gram positives and gentamicin gram negative. So a lot of organism gets covered. If the child fails to improve clinically within 48 hours, change the antibiotic to third generation cephalosporin, cefotaxime or ceftriaxone. Okay, this is roughly the thing. Yeah, antibiotic sensitivity. If the infected child or complications present, there is some issue. Ampicillin doses are important because, yeah, in pediatrics, the examiner expects you to know the doses. Okay, it is 50 mg per kg per dose, 4th hourly. Okay, gentamicin 2.5 mg per kg per dose, 8th hourly. That is 3 times a day. This is 4 times a day. Okay, that is ampicillin and gentamicin. And you can add cloxacillin. Cloxacillin is staph oriented. If there is a staph infection, you can do cloxacillin. Okay, staph pneumonia, staph skin lesions, we can do cloxacillin. Okay, you'll get cloxacillin tablets, but nowadays nobody is using. Everybody is using amoxiclav. Okay, but cloxacillin works well. Okay, ampicillin and cloxacillin is a combination that works well for skin and other staph infection. Yeah, okay. Fluoxetine dose of 100 mg per kg per day, 6th hourly. Okay. Remember, this is per dose, 50 per dose, and this is 100 per day. Yeah. For septic shock, you identify the child to be very sick, shock, and needs ICU management. You have done fluid management, you have done electrolyte management. Now you are doing infection management. You always do third generation cephalosporins. This is cefotaxime or ceftriaxone, 100 mg per kg per day, 8th hourly. Okay, 3 times a day. If you are suspecting meningitis, you do higher doses of cefotaxime, that is up to 200 mg per kg per day. This is because higher doses will result in higher concentration of the antibiotic in the meninges. Okay, so we want the antibiotic to go and pass the BBB, that is blood-brain barrier, and then make a good concentration in the meninges. So you do high doses. Okay, that is double the dose, 100 to 200 mg per kg per day. It is 150 to 200 actually. 200 every 6th hourly, that is 4 times a day with IV amikacin. 15 mg per kg per day every 8th hourly. Okay. Yeah, if dysentery is present, you imagine that we are dealing with E. coli or Shigella, that is mostly gram negatives. So you do ciprofloxacin 20 to 40, that is 30 mg per kg per day in 2 divided doses. And if the child is sick, we can also do fraction 50 mg per kg per day, OD or BD if child is sick. Okay. Why is it not working? Yeah, now the micronutrients, like all the things, micronutrients are come. Micronutrients are the components which are required in 10 to 100 micrograms per day. Okay, your daily allowance will decide what is the micronutrients and macronutrient. Your carbohydrates, proteins, and fats, those are all macronutrients. You need it lots and loads and loads. Micronutrients is something that we need less per day. Okay, those are the micronutrients. Yeah, your vitamins and minerals constitutes your micronutrients. Yeah, vitamin A orally if the child is taking well, and even the child is not sick and not in ICU or not in severe shock or stress, then you can do vitamin A orally on day 1. And we should give other vitamins daily, like folic acid, zinc, and iron. And these are the minerals we have to do every daily. Okay, this folic acid is 1 mg per day. Just remember easy. Zinc is already like 2, so 2 mg per kg per day. Iron is 3 mg per kg per day for first week. After the first week, okay, because iron itself causes a lot of issues, so don't do it in the first week, as we have seen it. All the micronutrients you should start from day 1, but only for iron we'll do it a week later. Yeah. Composition of mineral solutions, which we have discussed actually. Yeah, this is basically the mixture. This is the mineral mixture, which has to be mixed with the water so that the electrolytes and these micronutrients are come in proper proportions. Okay. This is potassium chloride, triphosphate citrate, magnesium chloride, zinc acetate, and copper sulfate. Okay, these are the numericals. Just go through the material, but remember that this is the vitamin mineral mixture. We have to be adding it with your ORS. I mean, whatever fluid we are giving, you can add it and you can give it. Okay, now about cautious feeding, how to start the feeding. Okay, small frequent feeds has to be started oral or oral route. If the child is conscious and well taking and eagerly taking, you can do it orally, or you may have to go put a tube and directly give it to the stomach or the jejunum. Okay, if the child is having more vomitings, you do it in the jejunum. Okay. Milk-based formulas like F75 contains. Why is it F75? Just like a fighter jet 75, it is 75 kilocalories per 100 ml mixture, which contains 0.9 grams of protein. This is again a viva question actually. F75 is 75 because of 75 kilocalories per 100 ml, and it contains 0.9 grams of protein per 100 ml. Okay, or we can do F100, which can be given later. That is again the name 100 is because of 100 kilocalories per 100 ml. Okay. If there is usually holiday Seeger's formula is followed for fluid resuscitation and other thing, that is 100 usually 100 ml per kg. But in case of these dehydrated kids, you can give 130 ml per kg per day. But if there is severe edema already there and oliguria, that kidney is not pushing out much, you take care when you are giving a lot of fluids. Okay. If the child is taking breastfeeding, always do breastfeeding. WHO always says breastfeeding. Yeah, next comes heart failure, because if you do more fluid IV, already the strained heart will fail. Okay, that is heart failure. And then monitor during the transition for signs of heart failure, like if there is a respiratory increase of 5 or more breaths per minute, or pulse by 25 or more beats per minute in 2 consecutive 4-hour reading, you should stop the fluid, IV fluids, okay, or decrease the fluid, okay, how much you're giving, because if the heart rate is increasing, that means the heart is taking more load on it, and if the respiration is also increasing just because of our fluids, so we have to cut down the fluids. Yeah, and once we start the feeding, now we are going to do catch-up growth. Okay, readiness to enter the rehabilitation phase is signaled by return of appetite. This is very, very, very important. That is important in red. Return of appetite. You just put this word somewhere in your answer sheet. Okay. Once the child can take by him or herself, usually after 1 week, that is when your rehabilitation stuff starts, and that is when the after critical management starts. Okay, recommended milk-based F100 can be used, as we discussed. It is F100 in the rehabilitation phase, and in the stabilization phase, we can do F75. Yeah, F100 is 100 kilocalories, and it contains more protein. Again, this contains zero point 0.9 proteins per 100 ml against point. Sorry, this contains 2.9 grams of proteins per 100 ml against zero point 0.9 grams of protein in F75. Okay. And rehabilitation phase, vigorous approach to feeding is required to achieve very high intakes and rapid weight gain. Now you do more protein, now you do more feeds, now you just stop the child, okay, so that the child can grow faster. How much faster, or what is the normal growth that we are expecting, is more than 100 grams of gain of weight per kg of his weight per day. Like say that if the child is at some 10 kg, so we'll expect that the child grows 100 grams per day. Okay, that is what 10 grams gain per kg per day means. Okay, and remember this return of appetite is important, and that will tell you when the rehabilitation starts. Okay, when to start from the stabilization to rehabilitation is what should we do is your F75, which are we are doing in stabilization phase, can be changed to F100 and increase successive feeds by 10 ml until feed remains uneaten. Okay, like you keep on increasing the feeds. You can do rapidly and aggressively in case of rehabilitation phase, not in stabilization phase. Okay, the point when some remains are consumed. Unconsumed, you have to imagine that the child is feeding well, okay, and 30 ml per kg per feed if that is left, and we can think of unconsumed. See, this is some starter feeds like F75, F100, and F135. Okay, those are the numbers of kilocalories per 100 ml of this thing. And again, this is how to make a mixture, and how much of energy or protein it contains. Okay, this is again another table, but only F75 and 100 are of interest. F30, 135 is not much available outside. Yeah, then comes your sensory stimulation and emotional support. Delayed mental and behavioral development is usually present because malaise, not playing, isolated, weak child. We can expect delayed mental and behavioral development. Okay, so feed the child well. And so and yeah, all the abstracts, tender love and care, cheerful, stimulating environment, structured play therapy of 15 to 30 minutes per day, physical activity as soon as the child is well enough, and maternal involvement when possible, comforting, bathing, feeding, playing. If the mother is feeding, the kids will take more. Okay, you ask the grandmother knows well. Yeah, and prepare for follow up after recovery. Like yeah, a child who is 90% weight for length can be considered to have recovered, and feed frequently with energy and nutrient dense foods. Give structured play therapy, and advise parent or caregiver to uh, bring child back for regular follow-ups, checkups, and immune boosters with immunization, and just ensure your vitamin A supplementation every 6 hours, and other vitamin and mineral supplementation as we discussed in the previous thing. Okay, now coming to the emergency management, what does we do in case of a severe malnutrition child who has presented to your ER, and how do you manage the child with uh, a child with shock who has presented to you? Okay. Yeah, coming to the fluid therapy in severe dehydration, use IV or intravenous route. If IV is fine, you do IV. See, this is the only thing. You make sure that in severe dehydration and shock, the words are important. Okay, only then we are supposed to do IV fluids. Otherwise, we'll refrain IV fluids. Okay. Yeah, Ringer lactate with 5% dextrose, half normal saline with 5% dextrose at 15 ml per kg per hour at the first hour can be done. And dextrose alone should not be used because dextrose being a osmotically active substance, it will pull more fluid into the circulation, and it will cause diarrheas. So we are not going to do dextrose alone or any sugar substance alone. We have to add with sodium or sodium chloride, or we can give lingeractate, which also contains sodium chloride and potassium and calcium for this stuff. Okay. Yeah, monitor every 10 minutes and assess after 1 hour. If there is no improvement or worsening, you should think of septic shock, or like you have to do antibiotics immediately. Or if there is improvement and severe dehydration and shock is to be suspected, because if it is fluid resuscitative, you are giving fluid and the child is coming back, that is a good sign. And then you do more fluids, 15 ml per kg per hour over 1 hour, and reassess. If the child is getting better and orally accepting, do oral ORS. And if the child is clinically not getting well, you can do 10 ml per hour, and slowly you can increase the feeds. Okay. And this is the acute management and ICU setup management. You just fluid resuscitation is the backup. Okay, on the background. And coming to the severe anemia, blood transfusion is required if your hemoglobin is less than 4%, or if there is any respiratory distress because of anemia, and if the hemoglobin beat at whatever number, 4, 5, 6, you have to give fluid, blood transfusion. Otherwise, in a stable child less than 4, you wait, and you can give blood transfusion if there is less than 4. Okay, give whole blood 10 ml per kg, slowly over 3 hours, and furosemide 1 ml per kg per, IV at start of transfusion can be given, because furosemide is to decrease the fluid overload on the heart. Okay, even blood is fluid and it is having, so you may have to do it. Okay. I think we lost the audio. I think. Can you hear me? Hello? Hello? Hello?
Yes, sir.
Yeah. Oh, thank you. Thank you. Yeah. Anemia. Remember the numbers. Okay. These numbers are important. HB less than 4 and stable. If unstable, less than 6. Okay. We do whole blood. Okay. Not the RBC alone. Packet cell RBC. We'll do the whole blood. And furosemide to decrease the load on the heart. If cardiac failure present, transfuse packed cells, because whole blood has more volume, so packet cells will be done. Once the heart is failed or impending failure, you do less on fluids, right? So we are not going to do whole blood, we are going to do PRBCs, that is packet cell RBCs. Okay, the usual stuff, monitor heart rate, respiratory and vitals when you're giving transfusion. Okay, give oral iron for 2 months to replenish iron stores. Okay, that too after the first week, after the stabilization phase only, we have to supplement iron. Okay, this is your emergency ER management. And now coming to the associated conditions. How do you do the associated conditions? Is your associated vitamin deficiencies, associated mineral deficiencies, and how are you going to supplement them in a case of PEM case? Okay. It is the first comes vitamin A deficiency, which is well associated with malnutrition. If eye signs of deficiency, give orally vitamin A on day 1 to 14. The age criteria, more than 12 months, 2 lakhs, 6 to 12 months, 1 lakh, and less than 6 months, it is 50,000. Cod liver oil is present. Outside, it is very difficult to get. Only the government supply is. Uh, we can get only from the government supply. Even we in our hospital, we get it from the government. And for adults, I mean, like in a better, an older child, aquasol oral can be available. Otherwise, it is very difficult to get a vitamin A. I mean, in lakhs. Okay, in normal multivitamin tablets, you get it only your peanuts. Okay, there's only a few thousands or hundreds of units, not like lakhs. You have to drink a bottle to get lakhs of vitamin A. Yeah, yeah, if coronary clouding ulceration, give additional eye care. And yeah, eye drops, because once there is clouding, the breach of cornea is there, and the chances of microbial, the bacteria can get inside and cause my corneal ulcers. So you do antibiotic eye drops, and atropine drops also can be installed to decrease the synic A formation. But I think you will be well versed with these things. You are fresh from ophthalm. Okay, now the skin changes, the dermatosis, your hypo and hyperpigmentation can be present, desquamation, ulceration, and exudative lesions can be present. Okay, and most commonly, something of interest is your zinc deficiency. Zinc deficiency produces acropathy, entropathic hemorrhagic. Okay, so there will be perioral and perianal excoriation, and multiple lesions will be present. It's very classic. Actually, pictures would have been nice. Actually, it's my bad. I should. Yeah. Next time we'll do the pics. Okay. Yeah, zinc deficiency is usually in the affected children, and skin quickly improves with zinc supplementation. And in addition, you can apply zinc oxide. Your lactocalamine is nothing but your zinc oxide. Okay, zinc oxide, castor oil ointment, and petroleum jelly, paraffins. You can apply on the raw areas of dry skin and all these desquamous skins. Okay. Omit nappies, because perianal and perioral lesions will be present in case of zinc deficiency. So don't do other wipes, diapers, and all stuff, because they will again start eroding the skin. Okay. Then if the diarrhea is present and it is still persisting, even after the diarrhea is the cause of dehydration and malnutrition, and again if it is persisting, even after the first week of this thing in the rehabilitation phase, uh, if it is there, you should go for investigation. Maybe an infection that is sitting there, and you should do appropriate antibiotics. Okay, maybe amoebiasis, maybe giardiasis, or something is sitting there. So send for stool microscopy, and then treatment is metronidazole 7.5 mg 8th hourly. That is 7.5 mg per dose 8th hourly for 7 days. Okay, amoebiasis is in the mind actually. Okay, giardiasis and amoebiasis. In amoebiasis, we will do in a higher dose, that is 15 mg per kg per dose. And if there is continuing diarrhea, we should also think of lactose intolerance, that is inability to digest lactose, and treat only if continuing diarrhea is preventing general improvement. And starter F75 is a low lactose feed. You can use it in case of if you don't get any lactose free infant formulas. You can do zero lac is a commercial preparation that can be available outside. Okay. And yeah, osmotic diarrhea, as the name suggests, it is osmotic diarrhea. More of osmosis, glucose is osmotically active, urea is osmotically active. So whenever there is uricemia or hyperglycemia, all these things, that osmotically very active. So we don't give more of calories into the diet, so that once the high calorie diet or high sugars in the intestine will pull water, all the water from the intestine or from the body, and it will just purge out with the diarrhea. So we don't do more of calories in the initial phase. Okay, so why? Because this is the concern, right? Osmotic diarrhea. Yeah, suspected if diarrhea worsens initially substantially with the hyperosmolar starter 75. Starter 75 has 75 kilocalories per 100 ml. So if after starting F75, if there is more diarrhea and stuff, so we should think of decreasing the calories in the diet. Okay, seizures when the sugar content is reduced and osmolarity is less than 300 milliosmoles per liter. In these cases, use isotonic F75 or low osmolar serial based F75, introduce F100 gradually, because you can't do it more. Okay, and if there are parasitic worms present and that is the cause of your diarrhea, you do memendazole or albendazole. Okay, 3 days management. And yes, in India, anything can happen. Tuberculosis can happen to anyone. Okay, if strongly suspected, if the contacts are present, poor growth, weight loss is there, chronic cough, chest infection, and X-ray showing MALNUTRITION positive chest X-rays showing features of TB, pulmonary TB, and if test is positive, you should always think of TB and manage the case of tuberculosis, because tuberculosis is one of the leading cause of malnutrition. Okay, now failure to respond. Okay, then what is the response of treatment is good weight gain is more than 10 grams per kg per day, as we discussed. More than 10 grams. Numericals are important. We are doing it again. I'm repeating it again and again. Good weight gain is the child should be growing 10 grams per kg per day. Okay, that is, then you're on the right line and you can continue the management. And moderate weight gain is 5 to 10 grams per kg per day. Then you should check on some other external factors you are doing, but why the child is not gaining weight is because maybe there is an infection that is sitting. So you evaluate the child, what is happening, whether the compliance is poor, maybe the child is vomiting it, or whether there is a sitting infection that is still there or present or not coming down. So the child is not gaining weight as adequately. Okay, then poor weight gain is less than 5 grams per kg per day, and the causes being inadequate feeds, untreated infection, and specific nutrient deficiencies, and tuberculosis, HIV, this comes under infection also, and psychological problems. Okay, psychological problems for the mother or the feeder or the caregiver, and even with the child. Actually, even the child can start vomiting for everything. And failure to respond, and for those who doesn't respond is primary failure and secondary failure. Primary failure is failure to regain appetite by day 4, and failure to start losing edema by day 4, and presence of edema on day 10. Still, if the edema is present even on day 10, that is what failure. Okay, and failure to gain at least 5 grams per kg per day by day 10. Okay, if that is not happening, then there is a primary failure. What is secondary failure? Failure to gain at least 5 grams per kg per day for 3 consecutive days during rehabilitation phase. In the stabilization phase, if there is less weight gain, no adequate weight gain, that is your primary failure. If the stabilization phase is good, going well, the child is gaining weight well, but during the rehabilitation phase, if the child is not growing well, that is your secondary failure to respond. Okay, these are the numericals. Failure to regain appetite by day 4, start losing edema by day 4, and presence of edema by day 10, and not gaining weight. Okay, and discharge before recovery complete. Yeah. And what are the discharge criteria? When are we going to get satisfied when the child is responding well to your management, and when are you going to send them home? Is recovered ready to discharge when reaches 90% of weight for length and no edema. Okay, and there is absence of infection, and eating at least 130 calories per kg per day, and receiving adequate micronutrients, consistent weight gain of at least 5 grams per kg per day for 3 days on oral feeds alone, and immunization has to be appropriate and continued, and caregivers should be sensitized to take and confident to take care of the child at home. These are the criteria to be filled when there is good weight gain, immunization is done, infections are not there, And when child is taking orally well the adequate 130 calories per kg per day, then that is when you can happily say that yes, the child can do well even at home, so you can discharge from a hospital setup. Okay. And yeah, the child is yeah, recovery complete by 90% of weight for length, but can be discharged early for domiciliary if the child is more than 1 year of age. Good appetite is there and weight gain. Edema is not there and antibiotics are already completed. Vitamin K is given and minerals to be given for 2 weeks. Okay. The mother available at home is motivated, trained, and can look after and confident enough and have resources so they can get the things at home. Okay, and whenever the mother feels the warning signs of drowsiness or any infection that is impending, the mother should bring the child immediately to the hospital. Only then you can send them home. Okay. And if after sending home, what are to be seen? Feed frequently, at least 5 times a day. And F100, as we discussed in rehabilitation phase, we need more calories, and the child can tolerate more calories. Not like in the previous stabilization phase, you can't do more calories because of the danger of osmotic diarrhea. So you can do more calories after rehabilitation phase or at home. And high energy snacks in between meals have to be given 5 meals. Okay, this is what Hrithik Roshan takes when he's doing bodybuilding, 4 to 5 meals per day. Okay. Yeah, assistance to complete each meal and give electrolytes and mineral solution, and breastfeeding should continue. Yeah, that concludes. I think it's an exhaustive session, and in the afternoon, so most of you, I hope good number of you are still awake, and at least most of you understood what the topic has been run back. Yeah, this is management. Everything is these 10 things. Okay. The rest is all history. Okay, just you do these 10 things, you will get good marks. You just sit and read. That is fine for the rest of the things. If any doubts, just we'll do the clarification now if somebody is having any doubts. If not, we can conclude the session. It is already 5 minutes past 3. Any doubts, guys? Hello.
No, sir.
No, Saket. Yeah, thank you. If there is no doubts, and yeah, then we can conclude, right?
Yes, sir.
Yeah, Sujit, thank you, Prakash, thank you all, thank you for your patient hearing.
Thanks.
Thank you.